Ultimately, through various interactions with these immunological cofactors, which is about a 6-hour lecture, we wind up with a child with brain inflammation, which is probably an inaccurate term. Brain immune dysregulation is probably more specific to what we're seeing and the ultimate result of autism. So, mast cell activation does a lot of interesting things. This is from a completely different group, and the meningeal mast cell activation is the inflammatory reaction that appears to be predating the experimental autoimmune encephalitis, which is a model for MS, multiple sclerosis. So meningeal mast cells seem to be the trigger behind migraines, multiple sclerosis, and appear also tied into Alzheimer's and other forms of neurodegenerative diseases. And very likely it's the meningeal mast cells that are the critical factors in the development of autism. Very complicated slide, but it just talks about this interaction between what's happening with the meninges from a microglial and mast cell perspective, and this crosstalk between microglial cells and meningeal-related mast cells and/or macrophages. Macrophages may be part of this whole syndrome. In fact, you can emulate this by stimulating, by immunizing rats to MOG, which is myelin-related protein. You can actually stimulate this pro-inflammatory cytokine release into the subretinal space and model the kind of inflammatory changes that are being seen. In fact, you can change, you can see these microglial cells in this picture change to these round, non-ramified form, which was presented earlier. And in fact, this is the pro-inflammatory microglial cell change that occurs after stimulation from the meninges. And that's in the cortex, that's not in the meninges, that's the actual brain parenchyma. The beneficial effects of these M2 state macrophages, and that's the M2 state, that's the M3 state, appears to be part of the healing mechanism. And when I saw some of the early literature coming out of the University of Florence describing the fact that they could actually see the macrophages shift from that pro-inflammatory posture to that more M2 healing posture, the same expected effects would take place with microglial cells. And in fact, those are the kinds of studies that I hope will be happening soon, right? With microglial cells? Sure, you're going to be doing those studies, aren't you? Yes, of course, as soon as the funding's there. So insulin-like growth factor 1 and 2 expression from human microglial cells and differential regulation of inflammatory immune cell mediators. So the microglia wind up being critical factors. Again, these are essentially residential macrophages within the brain. So mast cells and macrophages exert beneficial and detrimental effects in tumor progression and angiogenesis. So the status of the mast cells and macrophages and their crosstalk determines your tolerance for cancers. Now, I don't do a lot of cancer work, but I'd say probably 10% of my practice is oncology because of GcMAF. I didn't do any oncology until GcMAF, and then people started finding me on the internet and demanding that I take care of them. And they were persistent enough with their cancers and the need to have someone work with them with GcMAF that I acquiesced and took care of them. This is an interesting patient. So, this is and unfortunately, again, the ultrasounds are not as pretty on the projection as they are here. Here you can see normal muscularis and bowel. This is a normal portion of bowel loop being seen with ultrasound in my practice. This, however, in the same patient, is a solid tumor in the abdomen related to her ovarian cancer. Now, this tumor, which is about roughly 2.5 centimeters, went away completely within 7 days. Her CA-125, her cancer marker, went from about 5,000 to 3,700 in that same 5 to 7 days. That's pretty extraordinary. Now, it's going to take more than just GcMAF in some of these really advanced ovarian cancer patients, but that's pretty amazing. The other thing we did for this patient is we gave their intraperitoneal Golaic form of GcMAF. So this is the fatty acid component of GcMAF. And we gave massive doses, about 1,600 nanograms, 2 vials, into the peritoneal space. Gave it one vial intravenously, gave vitamin C at modest doses, 5 grams, nothing big, and then put her in a hyperbaric chamber to alleviate some of the pressure with some of her partial small bowel obstruction. Hyperbaric did a wonderful job for her. And this is her first meal in 6 months. Pretty remarkable. So she's not cured, she still has cancer, but that instantaneous response is dramatic. And it's very similar to the instantaneous response that we see in many of our children with autism. So, getting back to the ultrasounds and what's happening. So we have some normal criteria. Babies at birth have a 3.3 millimeter space on average in their subarachnoid space. There's a lot of fluid there to assist the baby in negotiating through the birth canal without having trauma to the brain. So there's some extra water to kind of allow the deforming and the molding of the brain and the skull to the birth canal. And that rapidly, within just a few months, is gone. And I'll show you evidence of that. It turns out that we used to think of benign extraaxial fluid in survivors of the NICU as being that benign. This article actually calls that into question in 2004 and says, no, it's not so benign anymore. It actually predicts developmental delay and mental retardation and cerebral palsy. So too much fluid in that space isn't benign, and too much fluid in that space is in fact an issue. And Dr. Gargari, you don't have to worry about taking pictures of all these. I'll be happy to send you the slides. So we applied and received government permission to do further research on this. This is our study on the use of linear 2D imaging of the brain to look at the extraaxial space in children with autism. The study is already, the preliminary results are in submission and peer review, and I wish I could tell you that they're accepted. But we have one reviewer who is a tough nut to crack, and we keep having to refine little points in the article, but we should be published soon. This is in fact what we expect to publish, although we're going to add extraaxial fluid to cortical abnormalities, so extraaxial fluid and cortical abnormalities in children with autism in Frontiers of Human Neuroscience, and it's been in submission now for about 2 months. This is our ultrasonographic window. So through the temporal bone, there's a thin spot of the temporal bone that Dr. Ruggiero was nice enough to train me on and to teach me about. And we can see appropriate areas of language cortex and the superior temporal gyrus, which is auditory cortex. And it turns out most of the work of language is actually carried out through the superior temporal gyrus, most of which is visualized through transcranial ultrasonography. If you go into a functional imaging scanner and you speak while they're giving you tracers, it turns out that you can see the majority of work in language is carried out by the superior temporal gyrus. And relatively little work is actually carried out through Broca's area, which is typically thought of as the expressive language cortex. This is our ultrasound probe. At Dr. Ruggiero's suggestion, we use a linear probe similar to what we would use for musculoskeletal investigations. This is the part of the superior temporal gyrus, the auditory cortex that's being just compared size-wise. This is approximately the size of the probe to about a 9 to 10-year-old child's brain. And this was published by Ruggiero and Cassini. And this is the normal adult anatomy. That's the bone. This is the meninges. This is the subarachnoid space. This is the cortex down here. Unfortunately, a lot of the detail of the cortex is lost in the projection. And this looks pretty good, actually, although you can't see the cortex down here because it's gray. But this is a 6-year-old. That's bone, meninges, subarachnoid space. And in many places, the subarachnoid space is actually in contact. Now, this is not the gyral summit. This is the superior temporal gyrus, but not at a summit. This is the cortex. It's very nicely layered. There's no issues. This is a normal child. This is a 5-year-old, and very little fluid here, although it looks bigger than it really is because of the projection, and a very nicely layered out cortex that measures 4 millimeters. And this shows it very well. This is the gyral summit, and actually, on my grayscale, there's about 0.1 millimeters So a very tiny space right here. So this actually extends a little bit further. Child with 2-year-old sibling. Unfortunately, these are really terribly projecting. I apologize. When you see the slides in the paper when it's ultimately published, you'll see that this is pretty much all filled in and there's essentially no space at this 2-year-old level. So this is from Weigel's group, looking at post-mortem studies of autism brains. And they talked about abnormal neurogenesis and dysplastic changes. And they see this kind of stellate form. And when our ultrasounds pass through this layer, they're uniformly reflected. But when they pass through this, it looks as though they're passing through water, and it's very dark with very little echo reflection from that area. Same when they pass through this. You see this layer is going to reflect as a kind of a band of dark space with a bright echo on the other side. We, in the paper, describe a scaling system of 1 to 4 for cortical dysplasia and 1 to 4 for fluid. And this is what we accept as normal, is below 0.05 centimeters is normal amount of fluid for children and adults. Anything above that is abnormal, depending on where it falls on the scale. So this is a MRI, and this child is about 6 years old, and we're going to compare this area of the superior temporal gyrus and this area of Broca's expressive language cortex, ultimately to ultrasound. And you can, even though it's pretty poorly illustrated here, I think you can see the meninges layer right here in this space. Now, the radiologist referred to this as a normal amount of extraaxial fluid, really because of their lack of precision and their lack of reference to anything outside that. This is probably 3 times more extraaxial fluid than is truly normal, however. And I'll show you why. So you can see here, this space correlates with this measurement, 0.14 centimeters, both here and here on the ultrasound. So the ultrasound clearly picks up this increase in extraaxial fluid. But right here is a defect in the cortex, which fortunately you actually can't see. This kind of dark, stellate-looking thing is abnormal lack of reflection, cortical dysplasia, which, if confirmed ultimately on more detailed MRI scans, would be able to determine this. This, you can see this kind of, maybe there's some lack of density here, but this is a relatively poor resolution, large gap MRI scan. Most MRIs take a gap of 5 to 6 millimeters, and most children will have a standard MRI that looks at between 13 and 14 slices of the brain, and you're missing tremendous amounts of pathology in that process. When you go to higher resolution, 3T or above machines with very narrow gaps, you can start to potentially see these sorts of lesions. This is a classic example. This is the cortex. You see a bit of abnormality of the density here. You see this white reflection. The reason this is white and this layer is white where the arrow is because there was no reflection of sound here or here. So there's more sound energy to reflect off the normal tissue when it finally hits it. It's not that this sound is reflecting in that way because that tissue is more dense. It's because there was no absorption of sound here. So this artifact is actually one of the things that we use to diagnose the fact that there's something missing within that part of the cortex. Again, you can see a very nice, well-described extraaxial fluid space here, which is enormous. This one is 0.14, way bigger than it should be. And then there's multiple lesions. You can see this white reflection. You can't see the detail off of this projection, but you can see this white reflection indicates there's multiple cortical abnormalities that are present within this part of the brain for the child. So this is part of the paper, and this was one of the just remarkable things that a child walked in with his twins. So 4.7 years old, fraternal twins. One's completely neurotypical and one is very autistic. And can you guess which one is autistic? Which one? A or B? How many think it's A? Show of hands for the A is autistic. How many think B is autistic? Okay, all of you that thought B was autistic are wrong. You haven't been paying attention. So B has a very narrow subarachnoid space. It's down at a range of about 0.01, and this one is 0.16. So this is a huge space versus, can you see where these two calipers are? Very, very tiny. So they're very close to each other versus how far apart these are. So this is an enormous space versus his twin, which has a very narrow space. And I apologize, could you see them the way I see them on my computer, you'd be very impressed that this is a very small space. They just don't project very well. You get the idea that this is actually fairly substantial, however. So the medical literature talks about a lot of what this is. If you go to the Shen 2013 article from the Mind Institute on increased extraaxial fluid as a predictor of autism, they have a very nice discussion of what they anticipate this space fluid being. Toxic byproducts of metabolism, pro-inflammatory mediators, chemical messengers of inflammation, all of that is discussed within the context. They also note that this abnormal CSF is associated with abnormal neuronal development and can affect neuronal migration. So that little bit of fluid doesn't seem like that much, but the chemistry of it is tied into mast cells, macrophages, and microglial cells all reacting with one another, and is critically controlling why your child or your patients are not developing and functioning properly. So, what do we do about it? That's usually the first question that my wife asks. Okay, so what, hot shot, you know when it's there, big deal. What are you going to do about it? Because if you can't do anything about it, why do you even care that it's there? Well, we think there may be some interesting things. We think that the literature has reported kind of inconsistently different responses. So it does look like there's a lot of pro-inflammatory cytokines, although I wish it was more consistent in the medical literature, which means that anti-inflammatories may be beneficial. Now, things like ibuprofen and other kind of standard non-steroidal anti-inflammatories have a long list of complications associated with them. But things like luteolin, which Dr. Theoharides has published extensively, are mast cell stabilizers that may be able to functionally work in this area. We also think very strongly that GcMAF has the ability to change the dynamic within the immune system in a favorable way and is actually anti-inflammatory in this neurological environment as opposed to pro-inflammatory. And I think that's why we see our children turn around so quickly with GcMAF. So this is the first paper published in the world on nagalase, GcMAF, and autism. We saw, it's kind of interesting how this all came to be. I first learned about nagalase from HIV literature, and I was looking for various biomarkers related to chronic infectious diseases, and I stumbled across nagalase. It's interesting. I started looking at nagalase more, very intriguing, and then for about 8 months there was no laboratory that could actually test that. Eventually, thankfully, Imar Vogler's laboratory, which is Health Exchange, yes, in Holland, came up with a nagalase test. So I started sending him a bunch of samples, and it turned out that the children with autism were having sometimes very dramatic levels, as high as 7.8, and the normal control range is up to 0.95. I don't know that 0.95 is ideal, but in some of the older medical literature, the treated individuals, the non-cancerous individuals, were down in the range of about 0.63. And initially I thought, wow, this is it, okay? So high nagalase, disrupted immune system function, we're onto something. And even though I don't think nagalase is essential in the diagnosis and treatment of autism, it's a very helpful biomarker, particularly when it's elevated. But don't let that stop you from using GcMAF. If the nagalase is normal, that doesn't mean the child is not a candidate for GcMAF. Fortunately, there's some very persistent mothers in my practice who demanded GcMAF despite a normal nagalase. And I very often give in to mother requests when they're really that ardent and convicted to do something. It turns out that the children with normal nagalase activity respond at the same frequency as children with elevated nagalase activity. So nagalase is an important dimension within immune system dysregulation, but it doesn't necessarily predict responsiveness to GcMAF. We found, however, that on average, we found out of the 40 children, 8 were females, 32 were males. We had a nagalase level up here of 1.93, which is very high. Now, after we treated them for, on average, 14 weeks with GcMAF, it dropped down by almost 50% to 1.03, still not in the normal range. But that reduction was associated with dramatic improvement in many of the children's autism. This is from the paper. Non-response is anybody, we didn't have anybody below a -1 on the CGI. The CGI scale goes from -6 to +6. Anywhere from -1 to +1 was considered by me to be a non-responder. A 2 to 5 or above was considered response. In the initial paper, we didn't have any 6s, but in subsequent observation of these children, some of the children have gone on to be completely recovered with no evidence of autism at all. This curve, over time, as you continue to treat, shifts to the right with more improvements at a higher rate. So as the children are treated for a longer period of time, the Poisson distribution shifts more towards the right side of the curve. So clinical global impression, if you see 3, which is moderate, these are kids who basically weren't talking but are now talking. They're not necessarily talking normally, but they had no words and now they have short phrases. 4 is considerable, so these are kids that are using sentences with relatively good pronouns. 5, they're nearly off the autism scale, and by 6, they no longer have any evidence of being autistic. This is remarkable. I have not done anything in autism that shows this kind of response curve over this short of a period of time. This was an average of 14 weeks of therapy. So I now have, as David noted, 3.5 years of experience treating kids with autism. I think we have the largest experience in the world, and about 3,000 individuals that I have from about 37 different countries. Autism is a pan-global disease. It's not an American disease, a British disease, a European disease, an African disease, a Chinese disease. It affects everyone around the world. In the US right now, the current data is that about 1 in 38 boys has autism. 1 in 38 boys. That's pretty outrageous. That's from the CDC that took a bunch of their catchment areas, put them together, and they did a survey. Now, you could argue that we're better at diagnosing autism, but let's be honest, by the time a child is 6 years old, it's pretty hard to miss autism. And I don't think we were so daft 20 years ago that when children entered school, we didn't realize that they had autism. We didn't label them mental retardation and miss the autism because the mental retardation statistics have not changed. So that population is not giving itself up to the diagnosis of autism. So this is a true new occurrence of a global pandemic of autism that we must get our hands on quickly because we're losing children at a remarkable rate. Fortunately, many of those children can be recovered with GcMAF and a constellation of integrated therapeutics, but this is pretty tragic. I have individuals from 18 months to 42 years of age, and as mentioned earlier, older individuals can respond dramatically to autism, dramatically to GcMAF. How can that be? I mean, they're supposed to be brain damaged for life. They're supposed to have no hope of recovery, and yet I have individuals that, in fact, most recently I was talking to a mom in Jacksonville, Florida, and she received Volaic, the liquid oral form of GcMAF, which has the oleic acid molecule attached to the GcMAF. And using a proper dosing schedule orally, her 22-year-old son, who was basically drooling on himself and encephalopathic, required round-the-clock assistance from people who came into the home to take care of him. Within 2 months, he's working at a restaurant, rolling silverware, and is getting paid for that. Doing his job, going to work on the bus, following the instructions. He's aware of the family. And for the first time ever, when he was asked, "What do you want for Christmas?" he said the name of his sister. His sister was older than him, had been very aloof and distant from him because of the severity of his autism and never really had much interaction with him. But he still was so social and so interested that he wanted to see his sister for the holidays as a way to kind of start relating. That's dramatic in a 22-year-old over just an 8-week period of time. I have a 42-year-old that went from being still fairly autistic to living on her own, getting a job, having her own car, own bank account, and now has a boyfriend, works at a grocery store as a cashier at 42. Took about a year of that. That's crazy. You just don't see those kinds of changes with other therapy that late in life. But it also says there's still an ongoing inhibitor present. As though these kids have chronic anesthesia of their brain, where they just can't turn on certain switches and find the connections. But the connections are not missing, they're just inhibited. Overall, the improved clinical global impression scale, we're responses of 3 to 6 or greater, which is where I consider it to be a sufficient response to really be noteworthy, all the way up to 6 out of 6, is 80% with extended treatment. 30% are getting fully recovered within 12 months of treatment, and that's continuous treatment for 12 months. It's not doing 3 months and stopping it, but it's continuous treatment for 12 months. 30% are going on to losing their label of being autistic. However, and this is very intriguing, 75% of my population seem to require the persistent use of GcMAF to prevent regression. So early on, we were saying after 14 to 20 weeks, okay, you're doing really great, why don't you stop the GcMAF? Every time we did that, well, not every time, but most of the time when we did that, we would see the kids fall backwards. And it's very frustrating if you've ever climbed a hill or a mountain, to be climbing up the hill and then slide back down and have to climb up the same hill again, over and over again. You don't want to see that for the children, to basically have to recapture that same ground of development over and over and over again. So where the parents were cooperative, and most of them wouldn't, they insisted on continuing therapy because they were seeing so many dramatic changes. And when the parents are really like, look, I don't care what it costs, you just have to make this continue to happen for my kid. That's pretty good evidence that it's not a placebo effect. Because we as parents, and I am one of those, have tried everything, we do all kinds of different things, and we pretty quickly get to know what works and what doesn't work. And we don't get fooled by placebo effects for very long as parents. It's either really helping your kid to talk or your kid isn't talking. And if your kid's really talking, you know. And if your kid isn't talking, you're aware of that as well. It's very much like insulin. If you ask me as a physician, Doc, I've been on insulin now for 3 years. Isn't my diabetes cured? Can't I stop taking my insulin? If you had no pancreatic insulin production, the answer would be, absolutely not. You must keep taking your insulin or you're going to be in the hospital. If you didn't have a thyroid gland, or you were profoundly hypothyroid because of long-standing Hashimoto's, and you said, I'm really tired of taking my thyroid hormone, I think I'm just going to stop, what would happen? You'd rapidly become hypothyroid and you'd become ill. And that's what happens with our kids. So it's as though they're not able to make functional GcMAF protein on their own, which implies some sort of hepatic dysfunction in the glycosylation of the manufacture of that specific GC protein. Because it's not just related to nagalase activity. Nagalase could destroy that so that you wouldn't be able to make GC protein appropriately. But even when the nagalase level is very low, the kids continue to be dependent on GcMAF externally. That needs to be further explored in terms of what that truly means. So I'm not done, but this is the immunological summary. Mast cells, macrophages, and glial cells are implicated in the creation of autism pathology. Medical literature is very clear on that, and there's abundance of good quality major U.S. medical institutes and other university hospitals around the world that have published that. Meningeal release of inflammatory factors, which has previously been unrecognized by mast cells and macrophages, likely increases the accumulation of that extraaxial fluid that we've talked about to create a toxic effect on the brain. And GcMAF appears to work through a process of converting macrophages and microglial cells from an inflammatory state to a more healthy state, as well as direct effect on neurons, and that's pretty extraordinary. However, many of my kids who get a lot better with GcMAF don't get better enough, and that's driven me to a concept of neurophysics. So how many of you study neurophysics and read neurophysics textbooks and the articles on neurophysics? Really? Nobody? Oh, a couple. So I love neurophysics. It's a remarkable thing. It turns out a few years ago that Dr. Jin and some of his colleagues at the University of California in Irvine hooked up with some researchers from Intel, and they tried to assess whether or not the brain works the way you think the brain works. So most of you, physicians or not, think the brain works by one nerve cell firing, creating a synapse stimulation neurochemistry crosses the synapse, crosses the synapse, and as those two come together, the next one fires, the next one fires, kind of like a domino effect, right? If you apply that to like a knee-jerk reaction with a reflex, that's perfectly acceptable. If you apply it to cognition, the mathematics quickly tells you that you wouldn't be thinking if you depended on that. So how do you actually think? The hypothesis that was generated by that team from UCI and Intel is that you think by one region of the brain, one center, and if you think about the brain, it's organized into various nuclei, centers of activity. So one region actually fires a signal, and the activity doesn't have to travel through the synaptic connections, but it stimulates functional change in another part of the brain. We can prove this. It's